Hello everyone. Just a small lecture to round off the neuro module with a couple kind of oddball topics. I'm just going to spend a couple minutes on this, even though it's actually a really big topic that has a lot of people affected by it. Fibromyalgia or other neuropathies is really common and certainly an important thing to understand for practice, but from a drug perspective, we've kind of already talked about it, and you treat it similar to other pain. However, there are some key differences. So basically, we don't really know what causes fibromyalgia, which makes it difficult to treat. If you do have something like a patient who's diabetic, for like a diabetic neuropathy, you can treat their diabetes and hopefully that improves the neuropathy, but sometimes the damage to the microvasculature can be done and permanent. It can be difficult to reverse that even if you manage the diabetes correctly. So that's why diabetes is, of course, important. One reason why it's important to manage it. And then post-herpetic neuralgia, post-shingles is going to be something that you can't really avoid necessarily either, other than making sure your patients are getting their shingles vaccine when recommended. And it basically is causing long-term nerve damage, which causes the pain syndrome. So treatment, you can use some basic pain medications. However, things like NSAIDs and Tylenol probably aren't going to be super effective for neuropathic pain. Doesn't mean you can't try them. It just means that it's not an inflammatory process by nature, so it's probably not going to be something that's helpful unless there's kind of an inflammatory pain going on at the same time. So drugs we use for neuropathic pain are primarily sort of different than how you might approach a regular type of pain. And there's a couple different categories. The first one is antidepressants. We haven't talked about these classes yet, but we're getting close. In fact, the next module is going to start off with depression. So we'll come back to these really quickly, but tricyclic antidepressants and SNRIs, or serotonin norepinephrine reuptake inhibitors, are commonly prescribed for neuropathic pain and are probably some of the most common treatments you're going to start somebody on for treating neuropathic pain. Especially the drug duloxetine or Cymbalta has been studied for, we talked about this for osteopathic pain as well, osteopathic pain. I'm trying to say osteoarthritis. I don't know if osteopathic pain is a real thing or not, but osteoarthritis pain, and using duloxetine for that. So duloxetine's gotten a lot of play as far as a pain medication. It was originally developed as an antidepressant, still is an antidepressant, but used very broadly for pain syndromes, and specifically neuropathic pain is one of the first areas it was studied. All these drugs, tricyclic antidepressants, we'll get into their mechanism later, but they basically do the same thing as SNRIs. SNRIs are just more direct, and what they're doing is they're blocking the reuptake, so reuptake inhibitor, SN, serotonin norepinephrine. They're blocking the reuptake of serotonin norepinephrine in certain parts of the central nervous system, which changes the brain's perception on mood. However, it also seems to have some sort of a downstream effect on different types of pain syndromes. Why that is, don't really know, but they do seem to work for that. Anti-epileptic drugs, the big ones are going to be pregabalin and gabapentin, as I mentioned in the anti-epileptic drug lecture. Valproic acid can also be used sometimes, however, it's not as commonly used for this term. Why these work, again, not exactly sure. Neuropathic pain is complicated, and I don't know exactly if maybe it's just slowing the impulses to the specific nerves by decreasing excitation. I don't know exactly, but there's a lot of theories out there, but I don't think anyone fully understands the mechanism. Other options, opioids, of course, would work for any type of pain. We want to avoid those if we can. Tramadol, because it has serotonin norepinephrine reuptake inhibition properties, can be an effective option if you're looking for something a little stronger with a little bit of minor opioid activity and some different mechanism of action there. Muscle relaxants, cyclobenzaprine, specifically for fibromyalgia, has been studied. IV ketamine, it would be more like if somebody has a severe pain and you wanted to treat them, inpatient, you could try ketamine. Topically, lidocaine is probably the most common one people are using for neuropathic pain, and specifically lidocaine patches are the popular choice there. It also comes in gels and ointments and things like that too. The patches are nice because you can leave them on all day. They don't get on your clothes or anything like that. And capsaicin is also used occasionally as well for neuropathic pain. Those are really the options. I don't really have a treatment algorithm for you other than just these are what people try for neuropathic pain. Certainly, I would say the two most common medications are going to be duloxetine and then gabapentin or pregabalin. with gabapentin being the more common one, the cheaper, older one. Restless leg syndrome. This is going to sound a little bit like Parkinson's disease as far as the treatment goes. It's not really the similar symptoms, but basically RLS is overwhelming urge to move legs associated with unpleasant, like pins and needles, almost neuropathic related sensations, neuropathic pain related sensations. There's a number of different non-pharmacological options listed here, some iron deficiency associations and things like that. However, can treat it with drugs, and we use basically the PD agents, with the exception of adding gabapentin in there too. Usually dopamine agonists are our drugs of choice, so we're going to either give pramipexole or ropinirole. One of the big things to know is that for RLS, the doses are quite a bit lower than for Parkinson's disease, like probably 4 times lower than Parkinson's disease. So we try and manage them with much less aggressive therapy, and it seems to be effective. Gabapentin and pregabalin work well, especially if your patient has impulsive tendencies and you're worried about the dopamine component. You can try this. And if patient has underlying anxiety, gabapentin and pregabalin are used as anti-anxiety medications on their own. And so if you have a patient with comorbid anxiety disorder, it can be a nice option for them. There is this product called Horizont, which is like an extended release gabapentin for RLS. It's really expensive, and I don't see it prescribed. I would stick to just regular gabapentin because it's pretty affordable for most people. Carbidopa, Levodopa, or Sinemet, used in small doses, usually just for bedtime, and that's it. That's where I've seen it prescribed, but it's not super common for this. It is used occasionally. Duration, normally when somebody is diagnosed with this, it doesn't go away, so it is often a lifelong illness, so considering that when starting somebody on a medication is important. It might guide your treatment. Maybe you feel more comfortable, for example, with somebody on gabapentin for several years versus somebody taking a dopamine agonist for several years. Bell's palsy comes up a lot if you work urgent care or emergency medicine. I'm not sure where else people see it, because usually it's what I see Bell's palsy. It's a younger, healthier person who comes in with almost like a stroke-like droop to their face, and they're wondering why that's happening because they're mentally intact. And so it can be kind of scary, but it's something that you'll probably see occasionally if you work emergency or urgent care. Acute facial paralysis, unknown cause. It likely has to do something with herpes simplex or zoster reactivation. You can't really confirm it, and evidence we have behind that theory is not conclusive, so we don't really know what causes it, but that's the theory behind it. Sudden onset of unilateral facial paralysis. Outcomes are pretty good, but severity can vary, and sometimes people do have fairly severe presentation. The recovery is usually within 21 days of onset. Recurrence is a 7 to 15% chance. However, the third to fourth attack is much lower after that. So if you have it once, you have a pretty small chance of getting it again, and then it goes much lower after that. It's kind of like we talked way back in the fall about valacyclovir and herpes. And once somebody usually gets a herpes outbreak, it takes a lot of people will never get another one again, for one thing, and then the small percentages of those who get the second one, most people almost never get a third one. Now, it's a very small percentage of people with a herpes infection that get it multiple times, throughout their life. Certainly, it's possible. Bell's palsy is kind of the same way, which makes it kind of link back to this. Makes sense, right, that it's some complication associated with a herpes infection. Risk factors, pregnancy, and family history of Bell's palsy are both common risk factors. Treatment, steroids and antivirals are the two treatments you want to try. Pretty much everyone with Bell's palsy is always going to get a steroid. This is the primary treatment. The antiviral is sort of like a maybe. Anyway, you do the glucocorticoid. You want to start it within 3 days of symptom onset, ideally. It's a high dose of prednisone, like 60 to 80 milligrams once a day for 7 days. Antiviral addition, the evidence for adding an antiviral really isn't great, but valacyclovir is a pretty safe drug to try. And so if somebody's got what's considered high-grade Bell's palsy, which there are different grades of Bell's palsy. I'm not going to go into them. They depend on the symptoms you present with. Basically, the more symptoms, the more severe symptoms, the higher the grade. And then they'll add on Valtrex or valacyclovir, TID for 1 week. And then you, of course, keep the glucocorticoid on board. So sometimes I get this because I think people don't see this very often and get this confused. I feel like I've gotten asked this question at least a dozen times in my career. Which one should I do? I know like one of them have the evidence and one doesn't. The glucocorticoid has the stronger evidence. So I always do the prednisone for your Bell's palsy patients. The antiviral is sort of up to you depending on how severe it is. Certainly if you had somebody with Bell's palsy and you wanted to prescribe them valacyclovir in addition to prednisone, even though maybe the grading wasn't that high, I wouldn't really argue with you on that, just because again, valacyclovir is a pretty benign medication. When all is said and done, there's not a lot of side effects associated with it. So up to you, up to the maybe patient's history. Maybe the patient has a history of zoster and you're concerned about that. Certainly, there's situations where you might be more prone to prescribing the Valtrex on top of it. However, for the most part, your prednisone is going to be your core for this. And then most people do get better with taking this medication. So that's all I have to say about Bell's palsy. Kind of an odd thing, but you do see it fairly frequently in certain settings, depending on where you're going to work in the future. All right, narcolepsy. Narcolepsy is something I haven't talked about yet, and there's a couple drugs, and the reason I put a slide on it is because there's a couple drugs that I really don't get a chance to talk about anywhere else. However, they are actually kind of common. So here they are, modafinil and R-modafinil. They sound exactly the same with the exception of the R. The R-modafinil is an enantiomer of modafinil, made by the same company. Modafinil is Provigil. It was the older one, the original one. It's been around for a while. Basically, it's a wakefulness agent that is not an amphetamine. So that's the important distinction. This isn't like a Adderall or a Ritalin type drug. Even though it's kind of used for the same type of thing, it should cause some sort of stimulant type effect. However, it's not an amphetamine. I've heard this drug referred to as legal cocaine by people. I'm not entirely sure where they get that because it doesn't seem to mimic cocaine specifically if you look at its mechanism. Basically, it interferes with GABA's inhibitory effects and allows you to stay awake that way. I think people, when it first came out, thought it had something more to do with directly promoting neurotransmitters like norepinephrine and serotonin release, which is kind of what cocaine does. And it doesn't really seem to do anything like that, actually. So whether it's like legal cocaine or not, I don't know. But the point is that for people with narcolepsy who struggle with falling asleep, this is an option you have. You could also use a traditional stimulant like an Adderall or a Ritalin, which I don't have on this slide. We'll talk about those when we talk about ADD in the next module. But modafinil technically would be indicated for narcolepsy. It usually gives you a peak effect about 2 to 4 hours later. Duration is about 15 hours. It's pretty well tolerated. Some people get headaches, other really rare side effects, some psych side effects too, so you'll see. But generally speaking, well tolerated in standard doses. And then R-modafinil is just a different enantiomer. It's got a bit better of a side effect profile if you look at its incidence reports, but essentially the same thing. All right, that's all I have for you. Really quick lecture, and that rounds out the neuro module.